Well, we've gone and done it again, apparently. We've gotten ourselves into a new epidemic, monkeypox, and that's what we're here to talk about. The numbers from the CDC as of mid-August shows some 39,000 cases worldwide, about a third of which, or some 13,000, are in the United States. There have been a dozen deaths worldwide this year, and half have occurred in Africa. We've invited two clinicians from New York who are familiar with epidemics to give us a more clinical perspective on things. Dr. Eric Meyerowitz is an assistant professor in the Department of Medicine, Infectious Diseases, at Montefiore Medical Center in Bronx, New York. And Dr. Stephen Baum is Senior Advisor for Student Affairs and Professor of Medicine and Microbiology and Immunology, Albert Einstein College of Medicine, Bronx, New York, and a longtime contributor to NEJM Journal Watch Infectious Diseases. Welcome to you both.
Thank you.
Thank you.
Dr. Meyerowitz, I'm told that you see a lot of patients with monkeypox infections, and New York is an epicenter of this outbreak. What raises a suspicion of a case, and clinically, is it easily missed? And what would you tell clinicians to be on the lookout for?
Thanks so much for having me on. Yes, it's certainly true. We're seeing a lot of cases right now, and there's definitely a spectrum of disease, and there's some heterogeneity in the presentations that we're seeing. So I think you definitely do need to maintain a high index of suspicion. The main features that lead people to present to care are severe rectal pain, severe pharyngeal or throat pain, and the rash, though not everyone has all three of these findings. So the illness course for most people that we're seeing begins with some general systemic symptoms, often including fever, muscle aches, or headache. And then the skin lesions often come a few days after those symptoms, although we've also seen them happen at the same time. And we've seen several individuals who've had no systemic symptoms with just some isolated skin lesions. Typically, the skin lesions have been in the genitals, so either on or near the penis or around the anus or in both locations. And in most cases, though not all, we've seen them spread to other parts of the body. Often there's been associated adenopathy, which is either painful or painless. The most common areas that I've seen is inguinal adenopathy, anterior cervical adenopathy, and submandibular adenopathy. And since seeing first of the few early cases that we saw here, I've been worried about the possibility of autoinoculation as part of the way the lesions disseminate. So one of the things that I counsel my patients early on is not to touch the skin lesions, or if they need to wear some gloves, or if they weren't wearing gloves, definitely to be washing their hands afterwards. And I've been counseling my asymptomatic patients in our STI clinic as well about this potential risk, because I think anyone who's seeing a rash now should be aware of that possibility. So early on, the skin lesions have looked many different ways. So it's not just those classic umbilicated papules, which I think are pretty easy to identify. But we've seen things that look like tiny red bumps, things that look more vesicular. What is helpful is later on they tend to crust in this very characteristic way. So after you've seen a few cases, it's something that's pretty easily identifiable, and is something to look out for. But obviously that's only happening after several days. All the patients, I think another important feature of the current outbreak that we're seeing is all the patients that I've seen have been men who have sex with men. And so I think this is a key epidemiologic feature, and something that is really important to be aware of as you're caring for patients. And so I think, to summarize it, as clinicians, what to look for, certainly a genital rash, or a genital rash that is more generalized, particularly if there are any of those systemic symptoms. And very, very important, if there is any associated proctitis or pharyngitis, that should absolutely raise suspicion for monkeypox virus infection.
The course of the illness, is it how prolonged is it in your experience?
So many, or actually most of the patients that I'm seeing are being treated with we're treating them with tecovirimat, which is also called TPOXX. So and it's not yet known if this is attenuating the illness. I'm hoping that it is, but what I've seen for most of those patients who have recovered is an illness of around 2 weeks. So that includes this prodromal period of, up to 3 to 5 days. And then the rash really does evolve over, over about that time. So the point that people are leaving isolation is somewhere around 2 weeks. We have seen some people also who seem to recover very, very quickly, but I think the average is closer to those 14 days.
So it's been in the news today and for the past several days that vaccines against monkeypox are in short supply. So what are you telling your patients who are coming to you and saying, "How do I get vaccinated against this thing?"
Yeah, so the New York City Department of Health here in New York has been distributing the vaccines as they receive them. They've been only receiving kind of small quantities at a time, and the vaccine appointments when they go live, they're often gone within 10 minutes or so. So I think it's been clear that there is a massive shortage of vaccines. However, in the last 2 weeks, there seem to be more, and the Department of Health that has actually been able to distribute vaccines to some community partners, including some clinics like our own. So I think there is more vaccine supply, and we've been told that there's going to be more and more even over the upcoming weeks. For people who are looking for vaccines, the first place to go is to contact their providers because they may have access either through their own clinic or through affiliated clinics, and also to look on the New York City Department of Health website or the Twitter accounts where there are frequent updates.
And as we noted earlier, there have been just a few deaths from monkeypox. But what are the most common complications of the illness, and what management strategies would you recommend people use to mitigate those complications?
Yeah, so I think fortunately, even though there's a huge amount of suffering that this is causing a huge amount of pain, we're not seeing tons of people who need to be hospitalized. There are definitely some, but the vast majority of people are able to be managed as outpatients. A couple of the deaths were due to encephalitis. I fortunately have not seen a case of encephalitis. But the most common things that really are leading people to present are this extremely painful proctitis and this pharyngitis. So I've had numerous patients tell me that whether they have pain at one or both sites, that they're unable to sleep at night because the pain is so bad. I had someone tell me the other day that the pharyngeal pain felt like swallowing glass. And I've had people who have known what anorectal herpes feels like, who've described the proctitis that they're experiencing from monkeypox virus infection to be the most severe proctitis that they've ever experienced. So I think the pain is really what's most noticeable and what's most traumatic for the people that are experiencing it. So anybody who's having those symptoms are eligible for tecovirimat, also called TPOXX. That's the antiviral that we're using. As I understand, there are going to be some randomized control trials that are going to be stepped up within the next couple of weeks. But currently, not all providers are able to prescribe it. It's prescribed through an IND with the CDC, and there are many and a growing list of providers who are able to do this. I can't say anything about efficacy, obviously, based on my anecdotal experience treating about 15 patients so far, but I can say that it's really well tolerated. So there do not seem to be significant side effects. And so, I think it's been an important tool that we've been offering people. In terms of managing the pain, so for the rectal pain, I think we're making sure that everyone is not constipated. So if laxatives are needed, we've been using those. Also using viscous lidocaine for the pharyngeal pain. We've also been recommending rectal lidocaine formulations as kind of topical anesthetics. Additionally, I think it's important to point out that we have seen some co-infections. So I think it's important to exclude syphilis, herpes, gonorrhea, chlamydia infections, and obviously to treat those if that's found. One other important complication I have not personally seen, but others of my colleagues have noted, is ocular involvement. So in those cases, tecovirimat would be recommended. In addition, the recommendation would be to use trifluridine eye drops. And anecdotally, I've heard people have had good experience with that. So in general, I think it's really important to be in close contact with the people who are experiencing monkeypox virus infection and to help them manage, but really just to manage these incredibly difficult symptoms because there's a huge amount of pain and suffering that people are experiencing from this.
All right, thank you. And Dr. Baum, you've written an interesting essay giving a historical perspective on this epidemic, comparing it with others we've recently and not so recently experienced. And we'll focus on that in a separate interview. But as an educator and an infectious disease expert, what can you tell your medical students and other clinicians who are encountering an epidemic for the first time?
Well, first, I'd like to say that my colleague, Dr. Meyerowitz, has done a wonderful job of summarizing the clinical aspects of this outbreak. There are a lot of sort of psychopolitical aspects of this outbreak as well. I think the world population is tired of outbreaks, and I guess has never realized that we live in a sea of germs that are just waiting to infect us. And monkeypox is not new to the world, but is relatively new to the United States. And I think that one of the teaching points to medical students is a quote that I like to use, that no man is an island. We are all very susceptible to infections that others have had. Airline travel has made it a matter of hours between the time that somebody's infected with something and the time that they can transmit it to someone in this country, the measure of contagion. And so these things can move fast. They will move fast. They don't need visas or passports. And we have to be aware that anything that happens anywhere in the country that's an infectious disease is transmissible here. Another important factor, I think, is there's been a lot in the press, and every time you turn on a reporter on TV, they make a big issue of the fact that, quote, this is not a sexually transmitted disease. Now, I think they're doing themselves and the population a tremendous disservice, although I understand why they're doing it. So it harkens back to the beginning of the AIDS epidemic, where everybody thought that one had to be gay to transmit this, and it was something about being gay that allowed you to get this disease and transmit it. And in a way, that may be true, but it's important to point out it's not what your proclivities are, it's what your activities are. And I think Eric has pointed out that currently many of his patients and everybody else's patients are men who have sex with men. And so I believe it is a sexually transmitted disease. If you went to a textbook and had a list of sexually transmitted diseases, you would not find monkeypox. But I think to deny that route of transmission, particularly in this country where it seems to be paramount, really messes things up in terms of practicing good epidemiologic. If you take that expression to its fullest, that this is not a sexually transmitted disease, it induces the people who are in the midst of this transmission environment to think, well, it doesn't really matter what I do sexually. And that could not be further from the truth.
And Dr. Baum, you've published a summary in Journal Watch Infectious Diseases just a day or two ago, and speaking of routes of transmission, about fomites in the case in, I think it was Dallas,
Right.
which may have been the index case in the United States, where virus particles, viable virus particles, were found on surfaces 2 weeks after the patient who was infected had left the apartment. That we know that smallpox blankets were distributed to Native Americans, centuries ago, and that was a very effective and murderous strategy. I wonder if monkeypox, being related to smallpox, would have the same kind of not lethal effect, but the same kind of transmissibility on fomites.
Well, that's why I picked that paper to review, and why I actually asked the editors to expedite review, because I thought that was an incredibly important and new fact, although as you point out, we shouldn't have been surprised about it. They both smallpox and monkeypox are part of the orthopox viruses. They're very, very similar. And so this demonstrated you described it perfectly, that this virus is found 2 weeks after no one was there to spread it. And its ability to spread infection has not been quantitated yet, but it's certainly the possibility is there, and it raises a whole new concept of getting patients who we see with monkeypox to make sure they don't share bedding with other people, that they don't share clothes with other people, that they don't share towels with other people, something that I don't think anybody's paid much attention to up to now. Maybe I'm doing Dr. Meyerowitz a disservice because he's been telling people that all along, but I know that it's not been in the current talking about this disease, and I think it has to be.
A mutual colleague of you both, Dr. Barry Zingman, has written a 3 or 4 page briefing for patients, and it's entitled "Monkeypox: What You Need to Know." And I'll put a link to that in this podcast. Is there anything else you'd suggest that clinicians might refer their patients to or themselves to for deeper reading about this?
I think that's a great resource, but you also referenced the New England Journal article with the major report from the 16 countries. I also think the case records from a few weeks ago of the first case from Massachusetts has some really helpful pictures. So actually, I've been with my patients who don't have monkeypox, I've been pulling up both of those to kind of go through what the rash can look like, and I think those sort of pictures have been really, really helpful.
Okay, I'll link to both those in the podcast as well. Well, I want to thank you both for your time this afternoon.
Thank you very much.
Thank you.
That was the 301st edition of Clinical Conversations, all of which are available free at podcasts.jwatch.org. We come to you from the writers and editors of the NEJM group. Our executive producer is Kristen Kelly, and I'm Joe Elia. Thanks for listening.